In this chapter, we will study nutrition therapy for HIV infections and AIDS. HIV stands for Human Immunodeficiency Virus. This virus targets the host immune cells, and infects them so they become centers for HIV reproduction. When HIV infection compromises the individual's symptoms severely enough, they will then start having systematic conditions, making the individuals vulnerable to altruistic infections, and this can cause disability or death. The complete term for AIDS is acquired immunodeficiency syndrome, and this name is very descriptive. So the word syndrome, this indicates that it is a combination of conditions. There will be many signs and symptoms. And this syndrome is related to compromised immune function, so immunodeficiency. This is the cause. And it is acquired, it is not inherited. So it's acquired by the infection of HIV. HIV is the pathogen that causes AIDS. However, as we'll see later, HIV infection does not equate to AIDS automatically. AIDS is a disease that has to reach certain criteria in order to have a diagnosis. And we'll look at what that criteria is in this presentation. In the world, there are more than 30 million living with HIV. Among these, more than 3 million are children, and most of them live in southern and eastern African countries. Unfortunately, every year there are 2 million new cases, so new infections. In the United States, there are more than 1 million Americans living with HIV or AIDS. The majority of the infections affect people who are among men who have sex with men and those in a younger age group. So, this is something that is pretty alarming here, because when people are affected at this young age, it poses a lot of challenges to their life. Because if we think about it, during the teens and the early 20s, this should be a time for people to be reaching full development, both physically, emotionally, and professionally. It's a very critical period. But with this type of infection, it's a lifetime condition, so it can take a heavy toll on the individual and their families as well. And also, there will be a burden to the cost to the whole healthcare system. So for someone who gets infected at such a young age, that means there will be a very long time for this person to have to manage the disease. And although we have a lot of effective medication or combinations of medications that are now available, but this does mean that they have to make some permanent arrangements and be accountable to manage their disease for quite a long time. Like all viruses, HIV relies on the host system mechanisms and nutrients to reproduce itself. So this figure here shows the life cycle of HIV. And we can see the virus, the HIV, when it is a free virus. The particle will travel and then bind to our cells that have the CD4 receptors. So remember when we talked about the immune system, we mentioned that certain immune cells can be classified based on certain markers on their cell surface. For example, among T cells, we have the CD4 cells and the CD8 cells. And another example, one subcategory of T cells, the helper T cells, those express the CD4 marker. So HIV is going to attack those cells with the CD4 receptors. After binding, the virus will inject its own genome into the host cell. So what we see here is HIV RNA. And then it will go through what we call reverse transcription making HIV DNA. So why is it termed reverse transcription? Well, it's because under most conditions, we use DNA as a template to transcribe and make RNA. This is the part of the central dogma of the flow of genetic information. But in this case, the flow of information is reverse. It is no longer DNA to RNA. Instead, we are going from RNA to DNA, and that's why we say it's reverse transcription. And for this reason, HIV is classified as a retrovirus. So the HIV DNA is then integrated into the genome of the host cell. So we can see here that for these human cells with the CD4 receptors, the double helix here that's brown is the human DNA. And then we have this blue double helix, which is the HIV DNA. So that's the portion that comes in as HIV DNA. So once this injection and integration is completed, whenever the host cell divides, that portion of DNA will also be replicated into the second generation cells. Then whenever the host cell needs to make protein, this portion will be translated as well. It will be expressed. That's why we say, we were saying earlier that these viruses rely on the resources of the host cell to reproduce themselves. And we can see after the synthesis of viral protein, so after the genetic expression, then it is budding off to form new virus particles until this new particle then matures and reaches the next CD4 positive cell. So then it just goes back up and starts back at number 1. So this is how HIV infects human cells, reproduces itself, and then infects more cells. So just some key points on the previous figure. HIV is a retrovirus and it targets CD4 cells. It can be transmitted via body fluid, including blood. And unfortunately, in the past, when we weren't as aware of the full capacity of HIV, a lot of people were infected through transfusions of contaminated blood. But now there's some measures to help prevent that from happening now. And for people who share needles, if they're using illicit drugs or not, they are also at a high risk for infection. And if the mother is HIV positive, there's a chance that the fetus, even before birth, could be affected as well. So we do have some newborns who are unfortunately born with HIV infections. One thing we need to know is that HIV attacks CD4 positive cells, and a lot of these cells, after being infected by HIV, become dysfunctional. For example, macrophages, we know that these are some of the big immune cells that can process antigen information and play a coordinator role in our immune function. But once they are infected by HIV, their function will be compromised. And if we think about this, why HIV is so harmful is that it attacks the defense forces of the body. This is why after infection, our ability to fend from other infections is severely compromised. And these types of complications, actually, they're usually the reason AIDS patients die. It's not from the HIV virus itself, but from other infections that occur due to this decline in immune function. Some people who experience primary HIV infection will feel like they're having flu-like symptoms. So this could be in the first 48 to 72 hours after exposure. They might feel like they're having a cold or catching the flu, so very similar symptoms. But as things progress, we will see CD4 cell counts decrease. So this is not a surprise because we know these are the cells that are targeted by the HIV. And these three factors have a strong correlation. So CD4 cell counts, viral load, and progression to the diagnosis of AIDS, these things are all connected. And we mentioned that after HIV infected patients or those people who are infected, they often develop those opportunistic infections. So this means that these infections usually do not occur or do not occur as frequently. But for HIV infected individuals, they frequently get infected, and in certain cases, the usual antibiotic treatment will not be as effective. And later on, we will see a whole list of particular infections that are opportunistic. Also, HIV infection can lead to severe nutritional decline, including wasting syndrome. Actually, as we'll mention later on, wasting syndrome is criteria used in the diagnosis of AIDS. This table summarizes HIV infection and the treatment. We can see that it affects a lot of organs and tissues in different symptoms, including the cardiac, neural systems, as well as the GI tract. And we do know that in our intestine, there are a lot of immune cells. So the infection by HIV disarms the immune system, which makes our GI tract a high-risk area for infection. So please pay attention here to the nutritional implications of HIV-related infection in the different systems. And this table continues. So really we can see the impact of the body is comprehensive. All of the major systems can be affected. And if we think about the whole system, usually HIV-infected individuals have elevated inflammation. And they have this elevated inflammation response because, unfortunately, we don't have a way to get rid of the virus. So this means that the immune system will always be trying to launch a response. And that itself will increase the metabolic rate of the catabolism of the tissue. So there is this war that's constantly ongoing here. Here is the summary of the AIDS-associated opportunistic infections. We mentioned that by definition, this type of infection means that people can get it, but rarely. They rarely get it unless they have AIDS-related immunodeficiency. That's when they catch this infection. Or when they do get infected with these opportunistic microbes, then the severity is much, much more compared to people who are not infected with HIV. Overall, HIV infection can lead to severe malabsorption, which will compromise the nutrition status and can lead to malnutrition. So we have different factors that push HIV-infected individuals towards malnutrition. For example, proteins are being turned over at a much more rapid rate, and the immune system activity is elevated, although certain cells are no longer functional, but this will lead to constant inflammation, which also increases the energy expenditure and the tissue wasting. So there will also be hormonal and nutrient metabolism alterations. And we'll see a lot of these individuals, they may have secondary diabetes as a result of the HIV infection or AIDS. And we will also have chronic diseases as a consequence of primary HIV infection as well. Neurological disorders associated with HIV infection usually are peripheral, and the patients usually either experience pain and numbness of their peripheral nerves. And some people may also experience dementia. We also have AIDS-related pulmonary disorders. So the signs and symptoms of this condition is very similar to what we talked about in regular pulmonary disorders without HIV infection. For example, people with this condition are usually short of breath from constant cough, chest pain, fatigue, and pulmonary hypertension. So if we recall what we talked about in COPD, all of these can contribute to increased energy expenditure. But that also means that they may not have good appetite, or they may not have enough energy to consume a full meal. So these impacts here are the same as what we see in the respiratory patients. And then for the cardiac system, the HIV infection could lead to inflammation and also alterations in cardiac muscle. So we might see cardiomyopathy and also artery disease. When HIV-infected people develop anemia, usually they have a higher prevalence in a more symptomatic phases. So when we think about when iron was discussed in advanced nutrition, we studied that for iron deficiency anemia, there are 4 different stages. So only in stage 4 can we see the actual decline in hemoglobin level or red blood cell count, because the first 3 stages, although the markers are already changing, but if we're just looking at blood cell count, we do not see anything abnormal. However, for HIV patients who are anemic, they usually have a lot of anemia-related symptoms that manifest. Obviously, this means it's more severe in those individuals, and anemia could be caused by hormonal changes, infection, and/or medications. So, quick overview. Right now, treatment of HIV infection and AIDS is quite advanced compared to back in the 1980s, and this is mainly due to the discovery of quite a few drugs that can manage the different stages of HIV infection. However, a lot of these medications have interactions with different nutrients. And as a chronic condition, individuals must take these medications regularly. Therefore, these interactions with the nutrition status will continue for a long time. And this is why dietitians play an important role in managing HIV and AIDS. So people who are infected by HIV can also develop nephropathy and HIV-associated nephropathy. People who are at high risk to develop this condition include those who are male, who are of African American descent, who are taking certain medications, and who have infections. Then the last condition we'll talk about for this slide is the AWS. So this is the AIDS-related wasting syndrome. We already mentioned why AIDS patients will have this wasting syndrome. It's because A, they have increased energy expenditure, and B, the condition, the medications, with all of this, a lot of them have interactions with nutrients, and can cause conditions that may compromise their appetite and absorption capacity. According to the CDC, if someone with HIV infection has experienced a weight loss of 10% without known cause, accompanied by fever or diarrhea for more than a month, that would qualify the person for AIDS diagnosis. So a couple of quick points here that we should call out. So we see weight loss of 10% without a known cause, accompanied by a fever or diarrhea for more than a month. So, we have to look at a couple different conditions here and make sure, and also if it's lasted long enough. So that was what will qualify for an AIDS diagnosis. So going a little bit more into how we diagnose HIV infection or AIDS, we have different lab tests that we can employ to achieve early diagnosis, especially at the early stage of infection. For example, we have what we call a P24 antigen. And remember, antigens are small molecules or parts of molecules that trigger an immune system response. And this response gives rise to the specific antibody attacking this antigen. So that's one thing we can look at. We can also check viral RNA or DNA. And obviously this is a very good test because we are going down to the nucleic acid level to test it. However, a lot of these tests do take a long time. So a combination of ELISA testing for antigen and antibodies can allow for earlier diagnosis of HIV infection. And a lot of these will have benefits in the clinical management because the faster we can get the results back, the earlier the patient can be informed and seek medical attention. Many companies have been doing research or developing a product that allows rapid HIV antibody tests. So why would we use a rapid HIV antibody test? Well, it would, by definition, all antibodies are proteins, and we know we just don't generate antibodies out of thin air. We have to be exposed to a specific antigen to produce a specific antibody. So after we have this exposure, our immune system will respond and produce that specific antibody attacking that antigen. Therefore, rather than looking into viral DNA or viral RNA, which could be direct evidence, we can look at the antibody against HIV as a marker. If this person is tested positive of HIV antibody and knowing that the antibody doesn't come from thin air, this means that the person has been exposed to the HIV antigen. So in this case, that means infection. However, it does take some time for our immune system to respond to this virus and to mobilize the production of the specific antibody. Therefore, there is a window period post-exposure where we would not be able to detect the HIV antibody. So right now, the recommendation is that if there is a perceived exposure or potential exposure to HIV, using the antibody test should be done at least 3 months after the perceived exposure because that's the time when we can begin to detect these antibodies. So if the exposure, had maybe been last night or this morning, when we go to have the blood test, our immune system hasn't had enough time to respond. So we won't be able to tell whether there's truly an infection or not by checking the antibody at this time because the antibody hasn't been produced yet. However, this type of test is very popular and convenient. It can be done at any clinician's or organization's office, and the individual can just wait for about 20 minutes and then they'll have their results. Also, in 2013, the FDA approved a rapid test kit to be used at home, which would definitely be more convenient and, of course, ensure better privacy. But we should know that a lot of these new techniques are not error-proof. So usually, if one of these tests is positive, then immediately for many states, they'll require a second test. And what we rely on to confirm is a Western blot test that will confirm the result from the rapid test. So the Western blot test, for those who have taken biochemistry, this is a molecular biology technique that detects the type and the quantity of proteins. So remember, antibodies are all proteins. Another point regarding the medical diagnosis of HIV infection is that, if during pregnancy, if the mother is HIV positive, then there's a chance that the fetus will be affected before birth. And from life cycle nutrition, we learned that those antibodies from the pregnant mother can stay in the newborn's body for up to 6 months after birth. So there is a possibility that a newborn is tested positive of the HIV antibody, but after 6 months, when we test the baby again, the baby will come back negative. So in that case, we would all be happy because even though there was a positive test for the HIV antibody after birth, it was due to the antibody from the mother rather than from the baby's own immune system. So this means that the baby was not affected. Another challenge to test newborns before they reach 6 months of age is that, like many systems in the body, the immune system in the newborn is not fully mature. It will take time for the system to mature, then react to infection to produce its own antibodies. So for this reason, a newborn younger than 6 months of age, it is hard to have a definitive test. And this population is the only population known to date that could have a reverse from HIV positive test to an HIV negative status. Earlier, we mentioned that HIV infection does not equate to AIDS because HIV infection only talks about the presence of a virus, so the presence of that pathogen in our system. However, AIDS refers to a disease state where we have lots of signs and symptoms. And the CDC has classified the infection of HIV into 3 stages. So obviously, when patients progress into stage 3, then that's where we can use the term AIDS. And obviously, like all other diseases, we have clear diagnosis criteria. For example, we look at lab tests. We check CD4 cell counts. So the CD4 cell count must be low enough for it to qualify for AIDS. And also there's clinical evidence, right? So we mentioned wasting syndrome. So for more than a month, if a patient experiences 10% weight loss without a known cause that's accompanied by fever or diarrhea, these are all things that we need to assess. And remember, for AIDS, the S is for syndrome. So when we see syndrome, usually the diagnosis is a checklist. Remember, when we go back to metabolic syndrome, it had to be 3 out of 5 features on the checklist for it to be diagnosed. So same thing with AIDS. We have to Have some lab evidence here and then also some clinical evidence as well. However, the World Health Organization has the somewhat different classifications of HIV infection. They also use different stages. And if we compare this to the classification to the one from the CDC on the last slide, the WHO criteria does not include CD4 cell count. So a lot of these are based purely on clinical manifestation. And the reason behind this, one of the reasons is that for the CD4 cell count, these kinds of labs may not be readily available in all the places where HIV infection is a pandemic. For example, we mentioned that there are more than 3 million children who are HIV positive right now, and the majority of them live in African countries with severe poverty. So the system just doesn't have to, they don't have the elaborate, expensive lab tests. So in that case, we will rely on some low-cost strategies to diagnose, looking at the clinical manifestations.